prolonged mechanical ventilation, which there's a definition for this. It's over 3 weeks of mechanical ventilation for more than 6 hours a day. So around the time we start talking about trach, you know, they're sort of meeting, and that definition varies depending on the literature you're reading. So that's the biggest cohort of patients, I think, in our unit are those that fail to wean from mechanical ventilation and need a tracheostomy to support them over a longer period. These two certainly go hand in hand, right? So patients that have neurologic compromise, whether that's an acute stroke, traumatic brain injury, you know, they may require a tracheostomy just to maintain a safe airway because they can't clear their own secretions. And they may or may not have a mechanical ventilator, but they just can't clear their own airway to maintain a patent airway. And then there's this category, patients who have airway obstruction. This patient in particular has had a laryngectomy. We certainly see other patients, right, with an obstructed airway, whether that's prolonged mechanical ventilation, then vocal cord paralysis, or even angioedema. Sometimes that doesn't immediately resolve and patients need a tracheostomy, or certainly we have a couple patients in here right now with either laryngeal cancer or head and neck cancer, so they require a tracheostomy just to bypass that obstruction. So the benefits are clear, right? You can, if you think the patient is going to recover, or you can get them out of these situations, it provides comfort. So we can often wean patients off sedation once they have a tracheostomy tube. You can do better oral care because you don't have all these tubes in the mouth. There really isn't definitive data that it speeds weaning off mechanical ventilation or prevents BAP, but certainly you can argue that it, and fundamentally and lastly, puts in a safe airway that then that patient can go out of an acute care ICU to a step-down ICU or an LTAC and disposition somewhere else to further their recovery. So that's the other benefit, is you can usually move out of the walls of the ICU in a step-down or more long-term care setting. So the laryngeal, there's a delay. Laryngeal handshake. We're all going to do this together. Have you guys heard this term by Rich Levitan? This is something I think everyone in the room should know, particularly the critical care fellows. I want you to do this. We're all going to do it together. So just take your hand, and I usually, my thumb and my index finger, and put it right under your mandible. And squeeze midline, and that first structure way at the top is your hyoid bone, right? So then, if you go down from there, you're pinching, you feel this second rigid structure. That's your thyroid cartilage, right? Now, when you're pinching your thyroid cartilage, I want you to slide your finger midline and go down that thyroid cartilage until there's a dip. Does everybody feel that? That's the cricothyroid membrane. I think there are 2 patients in our ICU right now that had to have a cric for, you know, a difficult to obtain oral and the tracheal tube. So that's your cricothyroid membrane. That cricoid cartilage, which is the lower lip of that, so you have the depression, that's the membrane, and then you have the cricoid cartilage. There are 22 circular cartilage structures in the neck. That cricoid cartilage that you're feeling with your finger is the only complete circumferential cartilage structure. Why does that matter? It matters because the trachea, the posterior wall, is a membrane, and it's a shared membrane with the esophagus and the trachea. So when we talk about manipulating the airway and shoving tubes in it, we need to be aware that that is a membranous structure, and only the cricoid cartilage that you're feeling is circumferential. And then from there, you can feel your tracheal rings. And so when they do perc trachs in the ICU, usually they're going somewhere between the 3rd and the 4th tracheal ring. When you guys do perc trachs in trauma, similarly, sometimes with open tracheostomies, so for patients that have poorly identifiable landmarks, so when you can't palpate all that external anatomy, sometimes they need to go to the OR with trauma surgery or with ENT surgery to have an open trach. And again, putting it somewhere between either the 2nd and 3rd or 3rd and 4th tracheal rings. So that's your anatomy. And arguably, we should, I mean, we're not going to say, hi, sir, nice to meet you, and go for their neck. But we should probably be doing the laryngeal handshake on all the patients we intubate to get a sense of what are their landmarks, because I will say most of the crics I've been involved in, they were unanticipated difficult airways. So it's an interesting term, and I think it's good to be aware of the anatomy. So I want to go over this, and I know this, again, seems really obvious, but as we go through the algorithm, there's a couple pieces here that I didn't understand when I was a fellow, or even more recently than that, so I do want to talk this through. So we all know that when we breathe, it goes to our mouth and nose, and something critical happens. It gets humidified, and there's also hair and cilia that remove particles, and then the air obviously goes down through our glottis into the trachea. We ventilate back out through our mouth and nose. stifled now by all the masks we have to wear. In the trach setting, so let's first say, forget that this is passenger valve. Let's say this is a cuffed tracheostomy tube, right? So the cuff is inflated. So if the cuff is inflated, any inhaled air from above is not going to make it down into the lungs. This patient with an inflated cuff is an obligate neck breather. Unless there's a leak, it's all going in the tracheostomy tube to the lungs, back out, and none of that air is going up, again, unless they really forcefully strain. None of that is leaking around, so they're not going to be able to phonate because they can't have air coming up to vibrate their vocal cords. So a cuff tube, the entire tidal volume is going in and out of the trach. So now let's say we lean off mechanical ventilation and we deflate that cuff, right? So now some of the air they inhale from above can get down in, and air goes through the trach because it's going to go the path of least resistance, but some of that inhaled air is just going to escape up, and they're going to lose some of that tidal volume through the cords. And so again, they're ventilating through the trach, but they're going to lose some of their exhale tidal volume, and as the patient starts to recover and they're generating more respiratory force, they can have a stronger and stronger voice. So what then does a Passamere valve do? So this is a one-way valve that allows air in, but not out. So what would happen if you put a Passamere valve on a patient with a cuffed tracheostomy tube that was inflated?
They won't be able to breathe.
Exactly. It's like putting a pillow over someone's face. So they would breathe in, because air would go in, but it's a one-way valve that can't get out. It's going down in the lungs. It can't get out anywhere. So I will admit to you that when I was a fellow, I had a patient in the NICU who had an auto-inflating Lavona trach tube. And I ordered a Passamere valve, a speech consult. So essentially that's what I ordered. I ordered for them to put a one-way valve on so the patient couldn't breathe. I didn't realize that was an auto-inflating cuff. So it's just important to understand these dynamics, and this is why we get speech involved, and I've now learned more about trachs. But don't write that order. Just understand that patients shouldn't be wearing this when they're sleeping. They should be awake, and they have to have their cuff down to tolerate this. If you're ever in an emergency, you can just pop that cap off. All right, so that's a little bit about the airflow. And then one other thing to say that, and I meant to say that obviously if we're here and we're just ventilating through the trach, we're bypassing the entire decontamination and humidification of the upper airway. So not only do we have a foreign body in the airway creating secretions, but now, unless we give humidified air, it can get really dried and inspissated, and this is why these tubes get obstructed. All right, so let's talk about equipment. I do have a Shiley with me. I meant to grab a Portex, but I'll have some slides about Portex trachs. So at the top here, this is the outer cannula, right? So this is pilot balloon, cuff, right? So inflating. So you can use a cuff trach like this to ventilate someone on mechanical ventilation. You need a cuff inflated, right, to not have a leak. This is the neck plate. This gives you everything you need to know about sizing. And I'm going to pass this around a little bit. That's why I like from that perspective, I like the Shileys and the other brands, because it says right on here. On the Portex it does, but it's clear. I just discovered this yesterday. So it's really hard to read the engraved size. So I found that because we wear purple gloves, you can just put your finger behind it and see it better. So anyway, the information that you know about sizing is here. It says size 6 DCT. Anyone know what that means? Just means disposable cannula tube. It's referring to this inner cannula as a disposable cannula. So why, if this is the outer cannula, why have an extra, just increasing resistance rate?
So you can clean it.
Exactly. We just said these things get gunked up all the time. This actually says straight from the manufacturer, do not clean or reuse. Now, I will say, every patient with a trach tube in the ICU or in the hospital should have a backup trach at the bedside. If you're in an emergency and that's not true, understand that you do have to have this inserted to be able to connect a bag valve mask. So if patients in respiratory distress and you need to assist their ventilation, and we've had this in the ED, they roll in distress and they have a XLT tube, which I'll talk about in a second. They pulled out their inner cannula and then we're scrambling to find the right size. So the inner cannula needs to be in to give positive pressure, but the reason it's there is so you can pop it out and clean it, because otherwise this would just get clogged and you'd have to decannulate a patient every time to clean out their airway. So there is outer diameter, which is the outer diameter of the outer cannula, and then there is an inner diameter of this before and after the inner cannula comes in. So that's why the sizing is so hard to figure out. So the outer diameter is actually this with nothing in it from wall to wall, and that's kind of what the size that fits in the stoma, right? The inner diameter is on this ID 6.4. When you insert the cannula, it makes it smaller. I think it's a 6. I would have to look at the chart. So it will tell you the ID and the OD. In general, I've thought to not worry about the OD. They're named for their sort of inner diameter size. But as we'll talk about with the cortex, the sizing, it doesn't have a great relationship with Shiley for the smaller sizes. So what is this at the bottom?
Drop trigger.
Yeah, what's that for?
When you're putting like a Shiley in for the first time because of the distal end, you want to like a smooth, like kind of help smoothly put the trach in.
So, exactly. So it looks like a stylet, right? And it functions like a stylet, but it has the opposite, a different purpose than an endotracheal tube. An endotracheal tube is flexible, so you need the rigid stylet to have it keep its form to intubate a patient. These are rigid. You can't bend this, but the problem with these, and then when I pass it around, it's sharp. Again, remember, that's a membrane. So even though this is equally rigid, it's rounded. And so when you are going at 90 degrees and putting this in, this actually, it's supposed to, you have to hold your thumb on it. It's supposed to protrude out the end. And the whole point is so this doesn't cut the back wall and cause a TE fistula. Good. All right. So when you, and we'll get to the algorithm, but when you walk up to get called on a rapid, there are 4 pieces of information that I would like to know. I need to know these 2. I would like to know 4. So the size, we already talked about that. That's typically referencing your inner diameter. It's right up on the upper left hand of the plate here. So size 6, distal disposable cannula tube, ID 6.4, OD 10.8. That's in millimeters, but it's a size 6 Shiley. You need to know if it's cuffed or uncuffed because you need it cuffed to give positive pressure ventilation. You can tell from across the room if it's cuffed or uncuffed, right? So how do you tell? It's got a pilot balloon, so that's really easy. You don't have to spend a lot of, sometimes it will be up in the trach tie, so a couple times I've been fooled, but if there's a pilot balloon, it's cuffed. Now it doesn't tell you how well the cuff's working, but if there's a pilot balloon, it's a cuffed trach. So you know right away looking at this, I know it's a cuff because I can see it. If it's on the patient, this will be on their chest. So this you should know just by looking at the patient quickly and then looking at their chest. You can know these 2 for certain. The reason for the trach, I would like to know if they have a trach because they've had a laryngectomy. I would like to know if they've had a trach because their vocal cords are paralyzed or there's an obstructing tumor at the base of their tongue that makes them hard to intubate from above. You may not get to know that, but if you have enough time, it would be nice to know that. And then finally, the date of placement is helpful to know. So why is that helpful to know?
Because if it comes out, it changes whether you're going to put it back in or intubate from above.
To some extent, it changes whether if a patient gets decannulated or through the course of working through an algorithm with a patient, you need to remove the trach tube. The patient is at highest risk of forming a false passage, meaning the tracheostomy is simply a tracheocutaneous fistula. It's a connection between the skin and the trachea. And this tract takes about 7 to 10 days to heal. Now, can you insert, into a false passage into the sub-Q at 14 days? Absolutely. But if you're under this time period, it's more, it would be safer to use the ambuloscope or something to scope it in to know that you were going into the trachea as opposed to a false passage. Beyond this time period, it becomes less likely. Like if I come up to a patient and they're like, I had this trach for 2 years, not to say I couldn't put it in a false passage. It's a lot less likely than a patient who's on day 6 post-op from a tracheostomy. All right, so I just have a couple different types. Again, I don't think we need to focus on the brands too much. I want to talk a little bit about, it sounds like we're going all cortex. Do you know, are we going to have some Shileys here? Does anyone know? We have both right now, but.
I think I'm removing all cortex.
Or all cortex, yeah. So I have some pictures here. So this is a metal Jackson. Oftentimes patients with laryngectomy might have a Jackson. Clearly, you can't mechanically ventilate a patient with respiratory failure with that. This is what that Pasteur valve looks like. There's a bunch of different colors, but that's that one-way valve. This is an uncuffed Shiley. It's actually fenestrated. So again, when someone's weaning, they're off mechanical ventilation at this point, we want to help them with speech. So we're encouraging more of the air to go up through the vocal cords. Why do I show you these? Just because I want you to understand that none of these are good for the patients that we're likely to encounter in respiratory failure. And so there are cuff Shileys, but you need a cuff tracheostomy too. So here's your pilot balloon with the Portex. My patient yesterday who had a Portex, they had this. Does anyone know what this is? Yeah, exactly. It's called the suction aid. Catchy. So I think it terminates here. Again, I haven't worked with these a lot yet, but it basically above the cuff suction, because you can imagine when you're suctioning down here. By getting pooled secretions up here, the thought is less ventilator-associated pneumonia. But just know that that's what that port is. That's for your suction aid, and then your pilot balloon, you can see. Awesome. So I pulled this up. Actually, I'm going to thank Yanika for this. She discovered this yesterday, and I asked her, added this to the talk, because I wanted to see, well, what if I have a patient on the floor or who has a Portex, right? So they have a size 8 Portex, and it falls out or it gets obstructed, and I need to exchange it. If I grab a size 8 Shiley, which is probably still stocked in the Airway cart, in drawer 4 in the code cart, which if you're on the floor, that's where you're going to find the trach tubes, will it fit? And I think probably it will. So the outer diameter, so the will it fit question is the outer diameter, right? So that's the diameter of the outer cannula. So 11.9 versus 12.2, I think probably that would fit. There is no size 4 Portex. And so you can see here, though, that the 6s, there's a big difference in 9.2 and 10.8. So I don't want to freak anyone out. This is not like an unresolvable situation, but just understand that if you're switching between brands, this is where it would be helpful to look at the actual outer diameter to see if it'll fit. I mean, if you have a patient at a size 6 Shiley that fell out, I mean, you could get or Portex that fell out that you grab a size 4. This is something you can look up, but I just bring that up because a 4 is not a 4 is not a 4. Does that make sense? All right. This is important. So I think a good analogy for tracheostomy tubes is candy cane. So you've got both, I mean, it doesn't curve all the way around here, but you've got your horizontal distance and your vertical distance. So, just like extra large t-shirts, there's extra large tubes, extended length. So an XLT proximal is where this is proximal, this is distal. So an XLT extra large proximal would mean you have longer horizontal distance. So who might need that? A patient with morbidly obese, right? So if you put in a regular size 8 and they really need a size 8 proximal XLT, you may not get all the way to the airway. And so that's really important. If they have a big mass or swelling in their neck, they need that extra long distance. So just know that if they have an XLT, that's what needs to be at the bedside, and that's what you need to use. Similarly, patients with tracheomalacia, where the balloon doesn't really seat right, they may need a longer vertical distance. This is distal, so this is a distal XLT. Does that make sense? The lady that we have in bed 28, she has I think it's a size 8 cuff Shiley distal, proximal XLT.
Is there a Portex equivalent or not?
I think so,
Okay.
yeah.
I know there's custom-made ones you can do because I've had ENT request them, but I haven't seen like a pre-made.
I actually have those at the desk around. And Mandy and you can print it for me yesterday. I was like, that's what I want. Yeah, I mean, I cannot imagine that they wouldn't have a Portex version of an XLT. I don't know that they call it that though, so that is something we need to figure out. They have this blue line adjustable. Yeah, I don't know what they call it, but they have a couple categories here, and some have longer lengths. So we need to figure out exactly what they call that. So this is where you find, in a rapid, if you need to get a Shiley, look in the code cart, the 4th drawer, the Airway drawer, you'll find it. This is an important concept. So twice a shift, the respiratory therapists measure the cuff pressures. Why is this so important?
If it's overinflated, you get necrosis.
Exactly. So this cuff is inflated, right? And the capillary perfusion pressure of the mucosa is around 30, maybe 35 centimeters of water. And so if you're inflating above that, you're going to cause ischemia. And when you cause ischemia, you can cause necrosis. And when you cause necrosis, you can erode into structures, specifically the innominate artery, and you can damage the trachea. So they measure these pressures because we don't want these pressures to become excessively high because that can compromise the tissue. Now, this comes up a lot in medicine, right? Like, what do we want the ICP under? 20. What do we like the intraocular pressure to be under? The setting of acute glaucoma or orbital compartment syndrome. 25 or 30, around there. What do we like muscle compartment pressures to be under? Bladder pressures. I just make this point that like each organ we want to perfuse, so whether it's the muscle compartment, the intraocular compartment, the intracranial space, or the tracheal mucosa, we need to have capillary perfusion in order to not have ischemia. So this is really important, and as we talk about hemorrhage, you'll see this becomes very important. So this is just a retrospective review of emergency medicine paper, honestly, but I've read a lot of these articles about tracheostomy emergencies, and this is typically the breakdown. So just as far as frequency, dislodgement being the most frequent, certainly infection, obstruction, bleeding, and stenosis. And we're going to go through, there's not a lot of exciting things to say about stenosis, so we're going to go through the first four. So dislodgement. I already said that half of airway deaths that occur in tracheostomy patients in the critical care environment are due to just this. Patients are encephalopathic. These are, they may not know what they're doing. They may dislodge the airway. You can see here how well this seats on his neck. The neck plate is right up against. He has nice clean trach ties. His intercannula is in place. And so not that you can always tell on exam if a tracheostomy tube is dislodged, but look at that. Look to see, how well the neck plate goes up against the neck. So this is sort of a dreaded complication, and I'll show you a picture of why, and we talked about this already, that if we, particularly under 7 to 10 days, pass the tracheostomy tube into the subcutaneous tissue, and then bag under pressure, what can happen?
Could occlude the airway.
So yeah, so you're not ventilating the airway, and you could be occluding the airway. You can also cause massive, so this is all massive subcutaneous emphysema extending up to the neck, all down and then what else do you see on the chest X-ray? It's not a great reprint. This is from a chest case report. Yeah, so deep sulcus sign, giant tension pneumos bilateral. So you can imagine this is a life-threatening situation, right? Because not only does he have giant tension pneumothoraces, but not only is this airway, it looks like they got it back in, going to be hard to reinsert via the stoma, he also looks difficult to intubate with all this swelling and massive subcutaneous emphysema. So how would you pick up on exam that a patient might have a dislodged tracheostomy tube? Well, obviously the lungs are compliant structures, so if they're on the ventilator, the high pressure alarm would be going off. They would be desaturating, because as Mike pointed out, you're not in the lumen, so you're not ventilating the lungs, and then you're also potentially with, the tube itself actually obstructing the tracheal lumen, so they're not even ventilating through the stoma. And then if you're using bag valve, just be very careful about bagging under forceful pressure if a patient has a tracheostomy tube, because that is a very dangerous scenario on that previous slide. So obviously they'd be desaturating, and then as we're going to go over very next, the algorithm that when you pass a suction catheter, you're not really able to pass it very far because you're just burying that suction catheter in the subcutaneous tissue. And then again, looking at that neck plate and whether it's flush with the neck, and when you try to manipulate it, it's not. And then always be cognizant when you're examining your patients, are they developing? It's very easy to pick up subcutaneous emphysema. It may give you a clue.
Well, you should try Untitled as well to see if
yeah, that's a good thought. Yeah. This is the algorithm. So this was published in the Journal of Anesthesia. And I really like this algorithm because I just think it's very organized, and it's the way we approach most airways anyway. So this is really important. The first step, the default action in all tracheostomy patients is to apply spontaneously breathing. Put on a face mask. You want to oxygenate the upper airway and the lower airway. So trach collar and face mask if they're spontaneously breathing, or in other scenarios, if they're unconscious and they need assistance, you need to bag both the trach and the mouth. So this is a scenario where call a rapid response, get help there, because you're gonna need sometimes 2 airway teams, one at the mouth and one at the neck. Why? Because you don't know when you're first meeting the patient where the obstruction, dislodgement, where the problem lies. So you actually don't know if airflow is getting in through above, below, neither, or one or the other. So this is really important. In all trach patients, apply oxygen through the mouth and the trach. The next step is to remove that inner cannula. Why would that be?
Obstruction.
Exactly. You said it was super common. So you pull this out, and you can either suction them through just the outer cannula, or grab the clean one at the bedside, or put this back in. Now your inner cannula is in place. You're really just looking for obstruction here, and that's an easy fix. And sometimes now your patient's improving, and you're done. So next step would be, if you remove that inner cannula, looks clean, you put a new one in, you're back in. You want to click that back in case you need to bag the patient. Now what's your next step? Suction catheter. So you want to pass the suction catheter through to see, can I pass all the way to 10 centimeters, or am I just going to 2 centimeters? Do I get a big mucus plug and now I'm better, or do I, pass all the way but there's no issue? So if you pass the suction catheter and you get a bunch of secretions and you're better, that's great. If you pass the suction catheter and you either can barely get it in, or you get it in all the way and they're not better, you move on to the next step. And the next step then is to deflate the cuff of the tracheostomy tube. Why would that be? So we just said that for positive pressure, it's patients in distress. We need an inflated cuff to not have a leak. So why in this step in the algorithm would you deflate the cuff?
Because you wouldn't be worried about leak right now. You'd be more concerned with an obstruction.
So could be worried about either, but yes, obstruction is the answer. So what if it's just dislodged and that balloon is exactly obstructing your airway? So then if you deflate, reposition, you're in place. The other option, or the other scenario is, remember we said, if this, say this is actually better seated, but say this is obstructed. So this isn't dislodged. So say it's all the way in the way it's supposed to be, but let's say it's obstructed with mucus, and you're bagging and you're not getting anything in, you actually need to deflate that cuff to be able to bag from above. Does that make sense? So if you're not, and this is why the default action is to do both. So if you're blocked here, you're also, because your cuff is up, you're not effectively ventilating from above. So it would troubleshoot those 2 scenarios. So you say you do that, you deflate the cuff, you reposition, you're still not better. The next step is to remove the trach. And I think that with all of us, myself included, this is the step that makes us the most uncomfortable, because we think this patient probably has a relatively difficult airway. Why would I want to remove the trach tube? But the counter argument to that is a dislodged or obstructed tracheostomy tube is not a benefit to your patient and arguably harming your patient. So you need to remove that trach tube, and now you're in emergency oxygenation mode. You are doing bag valve mask ventilation of the nose and mouth, so the upper airway, but you also want to do bag valve mask ventilation of the stoma. So how do you do that? Good. Who said that? Yeah, so pediatric bag valve masks, this is great for maybe us in the ED, like the PZD is right there, but I'm on Kelman 10 South. Like, am I going to run down to K7 or the ED? So what would be in every airway code card in the 4th drawer that you can inflate a little bit and it fits right on there? LMA. Yes, exactly. I thought this was genius when I read this paper like 7 years ago. I was like, oh my God. So an LMA, you can just inflate it, and now you're bagging here and you're bagging here, and now you need to intubate. If you're most comfortable intubating from above, you can absolutely intubate from above. If you have a scope and you can scope it in, or it's an old trach, you can intubate the stoma with the same size tube or one size smaller. So this again is why we have these backup trachs at the bedside. The other thing you can do is, if you're most comfortable with endotracheal tubes in that moment, you can insert a 6.0 endotracheal tube in the stoma. But save the person's life, do what you're most comfortable with. I think, I personally would at least try to intubate the stoma, but absolutely, if you need to intubate from above, intubate from above. When we get into the red algorithm, we'll talk about that. But this is the position. So I've had patients with a trach, and then we need to exchange it out, and sometimes we may involve the ENT residents, and maybe they're early in their training, like the patient's like sitting up. So I want you to go back to your laryngeal handshakes and put your finger on your cricothyroid membrane again, and put your chin down, like just be seated normally in your chair. Really small, right? And then you put your neck back. You can just feel it open up. So this is the position. If you are intubating the stoma or exchanging a trach, you want them supine. You can look for a sandbag. This picture is from the internet. I have never seen a sandbag. I'm making a joke. But you just grab a blanket. You want to get those shoulders back because it extends the neck more. And that's what opens up your airway. So this is the position you should be in. But absolutely, in an emergency, if you can't reinsert the trach tube, the patient needs to be intubated just like you normally would. And this is what it looks like. You pass the tube and you bypass the stoma. You're inflated. There's no leak. You can put some Vaseline gauze over the stoma. One issue I just want you to be aware of is that within 12 hours, that stoma, depending on how fresh it is, but it may close up to 50%. And within 24 hours, it's going to close up to like 90%. So, or maybe all the way. So once you stabilize the patient, if this was the intervention, that's totally fine, but then involve the service that placed it, whether it's trauma or ENT or interventional pulmonary, because you could potentially save that patient like a tracheostomy redo or replace or revision down the line if you get something into that airway. All right, I want to talk a little bit about laryngectomy. And you might, and I'm just admitting, when I came as a fellow, I didn't truly understand this anatomy. So who would feel more comfortable in a tracheostomy emergency intubating from above? It's totally fine if that's the answer. Raise your hand. Totally fine. So what if you had a laryngectomy patient? How many people would want to intubate from above? Anybody? So, I mean, no matter how good you are at airways, you can be the best intubator in the world. 100% of the time, you intubate the esophagus if you intubate from above. And so this anatomy, so there you're actually physically removing this larynx, and you're doing a surgical pull through. I'm not a surgeon. You pull this trachea to be a permanent stoma. So there is no connection between the upper airway and the lower airway, no matter what. So this is why this is the red algorithm patient. The fortunate thing is, there's a couple of features that might clue you into this. First of all, someone would probably know this patient had a laryngectomy. They would probably have a sign up, or they would have had a recent surgery, would know this. This is only 5% of trach patients. The other thing is that it tends to, because it's this permanent stoma, you know, you can just kind of tell from this picture this patient has a laryngectomy. But there is a possibility that you might not know this, but just understand that if a patient's had a laryngectomy, they cannot be intubated from above. They are an obligate neck breather at all times. So when we think about our algorithm, oh, here, this is just a picture of, I think this is a pediatric IL mass, just showing you exactly what you can do with an LMA. It's still okay to approach all patients with applying oxygen to the mouth because it's not going to harm the patient. Now, yeah, I guess if you knew they had a laryngectomy, you wouldn't be vigorously banging the mouth because you'd just be distending the stomach. But in the rare scenario that you might encounter a patient with a laryngectomy, this is still the default action. Oxygenate from above and below. You're moving through your algorithm. You're doing every step. Removing the inner cannula, replacing it, suctioning, still not better. Deflate the cuff, remove the tube. And now in emergency oxygenation, again, if you knew it was a laryngectomy patient, you would only be bagging the stoma, and then you have to intubate the stoma. This is why it's the red algorithm. So it's the same algorithm, it's just now you only have one intubating option. Now you can still use a trach tube or endotracheal tube, but you have to intubate the stoma. I'm not going to talk much about this. Just know that I've encountered these a couple times in the EQ and in the emergency department. This is actually an intentional tracheoesophageal fistula. So air from the trachea goes through this TE fistula that's been surgically introduced through this little button device, and it rattles the esophageal tissue such that it creates a voice, which I think is genius. This doesn't really obstruct the airway. Sometimes patients, if they have these, just speech therapy gets involved. In fact, ENT doesn't get involved with these patients in the ED when they have issues. They just want you to know, like, when I was a fellow, I had an incubation with a TEP, and I had no idea what it was, so this was one of those. Infection, only going to speak briefly about it. I think we all know that these patients are prone to infection. Having a tracheostomy increases the odds ratio in some retrospective studies by 6.7 for pneumonia. So think about gram-negative coverage, obviously MRSA coverage. But the biggest thing and I know this picture is gross. I'm sorry. But I think the biggest statement I would make here is really think about your patients in the ICU after you treat them. The nursing care required for trach patients that can't cough up their own secretions can be pretty extensive. And while, yes, the patient may be off the ventilator, oftentimes it may be in their best interest to go to the INCU where they can have continuous pulse ox and suctioning. So be mindful of when you have a tracheostomy patient, ask the nurse, like how many times are they requiring suction? We have had patients that, survived, just had amazing recoveries from critical illness to then go to the floor with a trach to get obstructed, to have a cardiac arrest, and then have severe anoxic brain injury. And it's not to say that patients with trachs can't get good care on the floor. They absolutely can. But these patients need a lot of monitoring. And if they need help suctioning their airway, just think about, you call the ED in the middle of the night, like just maybe admit them to the INCU till we figure out their suction requirements, because that can save their life, honestly. The nurses on the floor just simply, they don't have continuous pulse ox, and they have 6 other patients, so they just can't monitor them effectively. So bleeding. Bleeding, most often within the first 48 hours, is mucosal from coagulopathy. Often the thyroid veins, it sounds like Dr. Spalla thought we had a patient last night who, Kim and Rashna saved her life. She went to the OR, she got explored, it ended up being a thyroid venous source, it sounds like. The other source, obviously, the arterial vasculature. So the problem here is that the innominate artery, so remember we're inserting around between the second and third, or third and fourth, the innominate artery courses down here. So why would that ever be involved? Several tracheal rings below.
It's just too low.
You're gonna put it too low.
If it's too low, it'd be real low. But yeah, or what do we talk about?
Necrosis from over.
Yeah. So it's basically right there, so you're going in up here, but your balloon is down there. And if we overinflate, on a sort of continual basis, it can compromise this tissue, and this can honestly just happen. And then you're eroding. So not only do you have life-threatening arterial bleeding that with that size vessel would be life-threatening in any scenario, now it's going directly into the airway. If you've ever seen these patients, there is an 80% mortality to patients with TI fistula because this is a huge amount of bleeding in the exact wrong place, right? So fortunately, only 0.7% of tracheostomy patients develop a TI fistula, but in those that do, the mortality is over 80%. 50% of patients that get a TI fistula will have what's called a sentinel bleed, which is what I was so concerned was, and why I specifically called the ENT surgeon. I think trauma was involved, so thank you for your help on helping our patient last night. But I specifically wanted to know, because when I read the op report, it wasn't clear to me if they just scoped through an endotracheal tube, did we look at the tracheal wall between these areas? And he said they did, and there wasn't a fistula there. But really important, because any tracheostomy bleeding needs to be taken seriously because it could portend a future life-threatening bleed. So what do you do when this happens?
I think you're supposed to put your finger in the trach and flex down, right? And that's where.
That is true. So it's an anterior structure. So you're basically, I'll show you a picture. I love this. It's like, oh yeah, let me just walk up here. Yeah, like, oh, I can see exactly where I'm going. So what this really looks like is, a bloodbath. And you're not going to be able to see any literally like blood on the floor sort of scenario. But yes, so in this moment, it's kind of like the hyperventilating increased ICP. You don't want to do that over the long term, but in this moment, overinflate the cuff. Put extra air in the cuff, because if you do, and this actually might be what this picture is trying to show, you can potentially tamponade. If that's not effective, you're going to need to secure the airway from above with a smaller endotracheal tube. So yes, you can literally, it's like the ride the stretcher to the OR sort of scenario. There is no medical management of this. This needs to be, go to the operating room with either trauma or ENT. All right, and I'm going to end on a case. This is a real case. I wish Dr. Fredek was still in here because I know we would remember this patient because we cared for him. Jason may remember this patient. So this was a 44-year-old who unfortunately had a history of IV drug abuse, and he was found in Camden, had overdosed. Someone had called EMS, and when EMS got there, he had, like, I remember reading the H&P and the ED, he still had the syringe and his anticubital fossa. He was in PA arrest. They didn't get pre-hospital ROSC. They got to the ED. The ED resuscitated him and got ROSC after several rounds. But honestly, it was one of the most severe cases of anoxic brain injury I've ever seen. I mean, he was on like 4 sedatives with continuous myoclonus. It's just really hard. We met with his family multiple times. His mom was his POA and just really couldn't stand the thought of comfort measures. And so it was just really difficult. And eventually he did get a trach and he went to the INCU. The timeline of this might be distorted, but I then took care of him again in the INCU, and I was called into his room. He was in room 53, I remember, because he was desaturating. And so these were his vitals. He was on the ventilator at the time, sitting in the 80s. His temperature had been a little high that day. He was tachycardic. And on exam, he really was always comatose. He was in a vegetative state. But at this time, he was bronchorous, tachypnic, and really using accessory muscles. So any other exam features you want to know?
His neck. What does it look like?
He's got a size 8 cuff shyly in place that you knew because it's got the pilot balloon sitting there, and he's got a fair amount of secretions you can see. So what do you want to do? Never pass this around. I'll pass this around. Sorry. I want you guys to all pull out the inner cannula, click it back in, put the obturator in, pull it out, put the inner cannula back in, play with it. All right. So what would be your next move?
Pull out the inner cannula.
Before that.
Apply oxygen.
Well, he's on the ventilator, right? But we don't know where airflow is going at the moment. So our default action is apply high flow oxygen. So you can either bag him or leave him on the ventilator. He's via the trach, and then put oxygen on his face. Depends whether he's supporting his own respirations or not. Oh, I took your thunder. What's next? So you remove the inner cannula, and when you do that, you suction, and you can pass it all the way down, and you get this huge movie. What's next? So now he's getting better. You can bag, he's back on the ventilator. Stats are better. There's such a delay when I push these buttons. And then just for good measure, you order the sepsis pathway. You make sure he has good large bore actus. Remember, he's having low-grade fevers. You get fluids. You're going to do your sepsis reassessment note. And you're walking away thinking, I am the man. Oh. This is one of our ED residents, and he is awesome.
Oh my God.
And then you fall back because now he's desaturated. So now what do? You walk in the room, and these are his vital signs. Now he's really working. He almost looks cyanotic. He's working hard to breathe. He's tachycardic. He's very tachypnic. What are you going to do? This is actually not to be creepy and HIPAA compliant, but this is him. And a later encounter I have with him, but this is him. What's your first step?
Apply oxygen above the blood.
Same thing, right? We're not deviating from the algorithm. So you're going to oxygenate him from above, right? And below. So you turn it up. If he's on the vent, turn it up to 100% FiO2. Then what?
Try to pass your suction.
Yeah. Pull out your inner cannula. I'm being repetitive. It's purposeful. This is certainly something we can commit to memory, right? It's supposed to be just rote. You go in and you do this. You remove the inner cannula. This time you pull it out. Unique is going to do it. Pop it back in. Looks clean. No issue there. So after your inner cannula is back in, now what are you doing?
And a suction.
Suction, okay. You can pass your suction catheter all the way. It seems to go in all the way. You're suctioning. You don't get that satisfying suction of any secretions, and he's normal.
deflate the balloon.
Good. You deflate your cuff. Perhaps you're obstructing your airway. And if you are, or your trach is occluded, your cuff is inflated, you're not effectively ventilating from above, and you're not effectively ventilating from below. So by deflating your cuff, one, you can reposition your airway if it's dislodged, and two, now your bag valve mask ventilation from above is going to be effective with the cuff down. He's still not better.
Remove it and intubate.
So say it again, Maggie.
Is it remove and intubate as well?
Yeah, so you need to remove the trach tube. So now you're in emergency oxygenation mode. Again, you got people there to help you. You're asking for your LMA, right? You're going to bag the stoma, bag the mouth. And now you have two choices. You can either intubate the stoma or intubate orotracheally. So let's say you decide to, in this case, I'll give you a little more information. So always remember your physical exam, right? And don't forget about your ventilator waveforms, because you would look at them. This is him too. Oh, there's a delay, so it looks really crappy. But so this is pressure, remember? This is flow. This is volume. So you turn this up to 100, right? He's at a rate of 14, pretty big tidal volume. He's breathing above. So he's triggering each of these breaths. You can see he's really sucking down and taking flow here. This is why what should be a square waveform is distorted. What else do you see?
Closing tidal volumes.
You have a leak.
Big leak.
So you have one of two things. I won't confuse you. You either have a big leak, so you have inspiration, expiration, or you have delayed cycling, meaning this breath is too long and he's triggering the next breath and it's cutting off expiration. But zooming in, how else would you assess it quantitatively?
The inspiratory distress.
Oh, yeah, look at his volume.
Yeah.
So there's
Right.
500 going in and 260 coming out.
Yeah. So this is not my daughter.
That's pretty good.
So in real life, it took me a while. I walk in, this guy is exactly as described. I didn't know anything about this algorithm. I'm not even going to pretend I was in an organized fashion going through this. But after a while, I did realize that I could kind of sort of hear a leak, which was very much confirmed by his waveforms. And I was concerned because it was a pretty fresh trach. So I actually had involved Dr. Green was here at the time. And we ended up kind of scoping it in so we knew we were in the right spot. But this was just a cuff rupture. But the thing I want to point out with this, right, is that say we didn't diagnose that on the waveforms. If you work through the algorithm, he just had a major leak and was desaturating and he couldn't handle leaking half his tidal volume. If you march your way through the algorithm, whether it's an obstructed tube, an occluded tube, a dislodged tube, a cuff down, you're going to solve the problem. And so this is why the algorithm is good. I put in here just because my kids like balloons too, especially this one. Where's the arrow? This thing, there's such a delay. She'll get real mad if you take her balloons. So, approaching tracheostomy emergencies. I know I've been a little obnoxious with the algorithm, but that's the intent is to just repeat it so you really use it when you encounter these patients. So just relax. Technically, this is a patient with not one, but two airways, unless they've had a laryngectomy. So there's like an extra one that you can use. Be algorithmic. Approach them like you would any difficult airway. You want to apply oxygen from above and below. If they're not breathing on their own, you want to assist ventilation, oxygenation from above and below. You want to work through removing that inner cannula. If that's not effective, you're going to pass your suction catheter, and then you're going to move to perhaps this is obstructed or dislodged, deflate the cuff, and then move to removing the trach, emergency oxygenation, ventilation, remembering to use your LMA to do both, and intubate either above or below. We kind of talked about all this stuff. Really important to have a backup trach at the bedside, particularly now with some movement in brands and sizing, as I showed you with the Cortex and the Shiley. You just want to make sure that you have the right size trach tube at the bedside. I think that's all I got. Any questions? Did everyone get to play with the trach?
So let's say like a hypothetical scenario where you have the patient with the subcutaneous emphysema and you're not able to get to the stoma and he has a laryngectomy where you can't get
Yes, so you have to, there's no option from above. So you have to, I mean, yeah, you just have to get an airway. There's no other option. Yeah, and that's what's so scary about that, because you're 100% right that as this blows up with air, it's just going to make it harder and harder to get that airway in. That's why I think with that case report from CHEST, like I'm just impressed they got it in. Yeah, there's no other option for that patient.
Are there XLTs in the code cart? Do you know?
I don't think there are.
I know they put
remember
it in
we
the-
were gonna.
I know they put it in
we
the
got
ED.
some
They
put in the ED.
because that was an issue one time. But I don't know about the code cart.
But this is why if a patient has an XLT, particularly the proximal lungs, because you can imagine that like you could get by in a pinch
Right.
if they just had tracheomalacia and had a little bit of a leak with a distal lung,
But
but
like
like
with
a,
sub-Q air at least, like
Yeah,
if
with
that was an
prox-
issue.
yeah, proximal XLT. I don't.
I'd have to ask like Jim or Phil.
Just make sure all your INCU patients, your floor patients, your ICU patients with a trach have a backup trach. That's it.
Yeah, especially for the medicine residents and stuff. Like I find like when I go to rapids on the floors a lot, like the patients will, especially with the switch, I found like a lot of people didn't have backup trachs for their size or the wrong size. And trust me, calling down SPD and trying to find a trach takes forever. And the patient's like truly in distress.
So in that scenario,
Yeah.
you would just grab a 6-8 teaching.
Yeah,
That would be
exactly.
long
Yeah.
enough,
Yeah, exactly.
both proximally and distally, but
Ideally,
yeah, ideally. And I don't know if they're in all the floor code cards, I'm not sure.
That's so good.
Do you have any other input? I know you do a lot of these.
I just wanted, just to add a couple of things. Tracheal dislodgement and false passages happen a lot, way more than you expect them to. Because a lot of times, it's dislodged when the nurses are turning the patient and they quickly panic and just put it back in. So by the time you get called that the patient is desaturated and everything, you really have to know the history of what happened, what the events that preceded this, and suspect, the tracheal dislodgement and go through the algorithm of, trying to get the patient ventilated. The other thing is, a lot of times we say 7 to 10 days for the tracheal sutures. That's the reason why, because it takes about 7 to 10 days for that tract to really form, for that wound to heal. And then so by the time those sutures, after like 7, 10 days, if you take out the sutures, you're less likely, if you get a dislodgement, you're less likely to get a false passage, after that. But I mean, again, it can happen. The other thing is the dressings. Once we do the trach, we usually pack under so that it tamponades the veins that bleed. Usually those should be taken out 24, 48 hours. Unfortunately, sometimes it gets left in longer than it's supposed to. That causes pressure necrosis too. So you have a big gaping hole, sometimes very foul smelling, like infection, pressure necrosis around the area. Necrosis all the way and pops up your tracheal sutures come out, basically. So the flange is on there, but it's not holding anything. And those can get dislodged too. So that's just a couple of things.
The other thing I would say to the fellows in the INCU and push us as attendings too to take the time is like really do as many of these exchanges as possible. I know, and I don't want to speak for our own colleagues, but I think, if their patient's ready to be downsized and we call them up and say, hey, can we swap out the trach, the guy's doing well, we can downsize it. Just the more times you do this, the more comfortable you get. But even if they're stable and they're off the ventilator, like I approach it seriously when I put them in bed. I want everything at the bedside just in case, something goes wrong. You just want to have oxygen, bag valve, all your airway supplies at the bedside, even when it's just a routine thing where we're downsizing so the patient can swallow, right? So they can start to talk, swallow, be a normal person, mobilize. These are important things we can do for patients. Some of my best moments as a physician have been taking care of a patient in the ICU and then getting them in the INCU and putting on that passive ear valve and like talking to them, or downsizing their trach so they can eat. I mean, these are like life-changing events. So, but the more you do even the not in an emergency scenario of exchanging, manipulating these trach tubes, just the more comfortable you get with it. You were going to say something, Mike?
Yeah, do you ever, like if they're, 2-3 weeks old, just put them back in blind, or would you always go with like an ambuscope or something?
No, I mean, I certainly have. I mean, 2 weeks.
Because we exchange them blind.
Yeah, no, I certainly have.
Yeah.
I think if you look at the ENT literature,
They changed one like day 5.
Yeah, I think
Yeah.
anything, day 5, there's a pretty good bulk of literature says the track is probably okay by day 4, day 5. I think most people, if you aren't like a very aggressive head and neck program, wouldn't exchange before day 7, because there's really no reason to, other than if you're trying to get them out of the hospital, if you don't have the ability to do it right. I think one of the things that's always a challenge is when they get dislodged, realizing that, the stomal closure can happen pretty quick. 12 hours out, I mean, these things really can start to close in on themselves. So like when they pop out and the patient's doing great, and if you're a hospitalist on the floor, you say, oh, we'll just let somebody take care of it in the morning. By the morning, it might be a little bit hard to get in there. You may have to dilate that stoma to get the trach back in. So still let somebody know, you know what I mean, to put it back in, even if the patient's doing well, after their trach dislodges. Because I just had somebody consult me when I was at a different hospital in the middle of the night because it came out in the morning and nobody put it back in. And by the time I got there, it was all, you could already see it was starting to close in. So we had to dilate it, put it over a fiber optic bronch to make sure that it got back in position and it caused a lot of bleeding. But yeah, I mean, and I think the passenger valve is another thing to understand, right? We get excited. You have to know how they work, right? So I guess, with a passenger valve, if you ended up changing out the patient's trach because of some mucus plugging and then you put in a 6-0 cuffed trach and then they did great and they wanted to talk again, would you put the passenger valve on? The answer is no. So if you have a cuffed trach, don't put a passenger valve on. The patient will suffocate to death. Okay? So I mean, like little things like that, is the reason why you should really get comfortable and really talk about these things, because more than intensivists, and surgeons care for these things on a regular basis, but a lot of the people who are not in the ICU will be caring for these patients on the floor. So the little things like that can save a life.
Cool, guys. Thanks for coming.
Yeah, and we'll play with the TIA fistula.
Okay. You have a fig or something?
Huh? No, we just have one that we have like a trach that shoots blood out of it, so it's always fun. But yeah, we do like the like. Has anybody ever cared for a patient with a TIA fistula? It's until you do it, and once you do, you'll never forget it. But I mean, your approach has got to be very, very clean. You know what I mean? Trying to identify who has airway contamination, who doesn't, who needs direct pressure, who should be intubated from above. So we'll run through all those things. Always ending in surgical hemostasis, right? I mean, I think
Always starting in call a surgeon.
Yeah.
Right now.
The idea
Have you called me yet?
of identification by bronchoscopy only works about a quarter of the time to actually identify the fistula, and CTA is only about a third sensitive for identifying. So all of those things delay, and any delay to hemostasis results in 100% mortality. So we're going to go through all of that.
I don't think you're even going to see anything with the bronch.
I don't know. Like people talk about trying to localize it with the bronch, like you're going to do something about it.
Well, I would think the role for a scope for the most part is like you have your sentinel bleed and then it's kind of not really bleeding and then you go in and like, well, how does that area look? Which is why.
Yeah. I mean, I think, it's sort of one of those things like airway contamination, trying to make the decision whether or not you have airway contamination makes you decide whether or not you just hyperinflate the cuff and put local pressure versus removing intubating from above and doing little Dutch boy. You know what I mean? So that's a big call. And like people want to go in and bronch to see if they have airway contamination. It's a clinical diagnosis. But you can certainly see a lot of airway contamination if you've ever bronch. But in those situations, when you haven't worked through it in your mind, you just start to gravitate to the things that, you think makes sense. And any delay in surgical intervention results in 100% mortality. And, there's a lot of talk in there's a lot of case reports, I should say, about endovascular coiling in those situations.
Yeah, I mean, I'm just
I
trying
just
to
have no
picture
idea,
the
No.
slow roll,
Yeah.
fistula.
You go to the basement and, you hang out with the interventionalist, but it's really interesting. I mean, like the last case that I saw, it was in a chest paper, it was like 36 coils to get hemostasis. I don't know who's got that much time. But the sentinel bleed, the sentinel bleed is a very important concept. About 50% of these patients are going to have this sentinel self-limited bleed, and you're going to say, oh, a bunch of blood in the anchio, and then it stopped. Oh, well, we'll just keep going about the rest of our lives, and then the next time it's game over. And then timing, very important. Anything, 48 hours or sooner, probably venous bleed, probably hit.
Yeah, so I meant to say that actually. So 3 days to 3 weeks. So a few days, because it takes a while for that to happen, to a few weeks. Could you have it a month out? Could you have it 5 weeks out? Absolutely. So that lady that bled last night, I mean, she's certainly right in that time frame. But that would be the most common, a few days to a few weeks.
And you always get nervous, like the thinner, younger patients have the higher.
Oh, I don't know. It's just a terrifying diagnosis. Hello.
Hi.
You missed the case presentation. It was one we took care of frequently, the anoxic brain injury after a heroin overdose. I know you remember. Yeah.
That makes
Thank you.